I guess everyone probably here knows that our real contribution to cruciate surgery was TTA. This is what Keon had the biggest success with. We started in about 2003, it picked up really fast, and it remains the main product for Keon as far as business goes, by far. When Barclay Slocum was still alive, and we had some contact because of the total hip, at one time when we went and did some hip surgeries with Barclay, I really did not want to even think about doing TPLO for, I guess, all sorts of good reasons, like respecting his contribution. So we didn't want to look at TPLO. But we also were very convinced that TTA was better as a procedure, so why would we get into TPLO if our consent, I would say, for those years with people who worked on TTA was that this is a better procedure. The turning point was ACBS meeting in San Antonio, where, although it's only had John D. came by with a glass of whiskey filled up and said, you got to do TPLO for good reasons, I suppose. And I'm very glad I finally gave in because on the business side, this is what these Fidelio guys, I'm sure, are happy that we started with. TPLO is growing the fastest in our program and may catch up with TTA in a few years. And we decided we will not teach TPLO. We'll just get some business out of this. There are a lot of people doing TPLOs, so we'll make it available. We're not going to run any courses. Let's just get some money out of this whole thing. And then it turned out this is just not viable. If you're going to have a product line, you've got to teach this. There are new people coming in. So we said we got to teach some courses. And as we prepared, I guess, for the first one, we looked at a bit of a problem trying to answer this important question. Either TTA or TPLO, you can look at as a rotation here. In one case, we are rotating patellar tendon on average by about 12 degrees, and TPLO calls for about 20 degrees rotation to get the same result. So how come you need almost twice as much to do TPLO, about right, as you need to do TTA? So this brings this thing around here, and we started looking at what TPLO actually means and is. And I would say now we're actually trying to make TPLO a better technique. This was certainly not our plan or intention, but it seems we can do TPLO a favor by looking at it closer. So these are the key words here. So what is plateau? By plain English, there's got to be something that's flat, like a plateau in geography or whatever is a flat plane. Is there anything that's flat in there? Or is this simply a wrong term to describe the plateau of the tibia? And then leveling. What do you level with respect to? This is a crucial question. You've got to know what your reference is if you're going to do this. And the definition of this from the beginning that Barclay Slocum introduced is tibia axis. There is a tibia axis. Some people call it mechanical or long. And that's our reference line. We're going to level with respect to that axis. Is that a justified idea here to do that? And what is it based on? And then comes the main term, which is slope. As soon as you say slope, you know what you're talking about. It is the slope that we're trying to counteract so that we don't have instability in the joint. So what is that slope? Where is it coming from? So we come back to these terms. So what is plateau? Well, here's an image from, I guess, not maybe the most current, but this is Tibial's book, page 911. You look at this cross-section on the medial side of the stifle joint, and if this is roughly what you would call plateau by looking at x-rays, and you look at the condyles, in this case medial condyle of the femur, why would we not call this one also a convex surface? That's what it is. They're both convex surfaces. There is nothing flat in there. So I think this is the beginning of the problem here, that we look at it as a flat surface and it is not. So here's this scheme that I guess everyone is very familiar with. We have either a cylinder rolling down a slope, maybe a little cart that runs down the slope, and there's this angle here. This is the slope that we're trying to counteract. Now the reason this cylinder is going to run down the slope is that the force which is coming straight down and the support by the slope, between the cylinder and the slope, they're offset here. So this thing will roll down. So what do we do to level this? Well, we do this. We turn this plateau, this plane, until this reaction force comes right under the force coming down from the cylinder, and now we're going to be happy if we did this. Now, unfortunately, that's not what we are dealing with. We have a circle here. This is the femoral side, the condyle of the femoral side, and we'll just make it a simple picture to start with, and we put another one below, which is the tibial condyle, also with the same radius of curvature. And now between these centers A and B, we draw the line and we draw the common tangent between those. We connect the A and B, and where they cross, this is the point here where they touch. This is the point of contact. Now the force is coming straight down as before. The angle here is alpha, that's the slope here. And the force is coming down. So this thing is going to roll on this cylinder. This cylinder is going to roll on this one. There is no plateau here. So we want to straighten this up by rotating that bottom cylinder by doing exactly this. We need to bring this cylinder to this position, and then it's going to be equivalent of bringing that plane under the contact here. So B needs to get to B prime here. How do we do this? Well, we need to pick the point around which we're going to rotate this cylinder to get to this position. This is the center rotation of our cut for TPLO. If we do this, it's going to be okay. So if you connect B and B prime and you take the bisecting line here, you could pick center of rotation to bring this here, anywhere on this line. Well, we're going to pick it here in the middle. This is our center of rotation for the TPLO cut. And how do we do this? We take this distance from here to here. That's this circle. It's a little bigger than either one, A and B. And we do this. We're going to rotate this now from here to here around this point. This angle here is the same as alpha here. That's the slope. So if we rotate around C, we're going to bring B to B prime. How big is this angle? This is the angle for rotation. That's the TPLO corrected angle. How big is it? It's not alpha, it's 2 alpha. So you need to rotate twice as much as what you think you need to do if this was a plateau. And geometry here there's no discussion about this. This is this simple geometry here. If you have a center, you connect it to 2 points here. You have the third point out here. This angle is twice as big as this, wherever this point 8 might be. So this tells us something about the fundamental problem here. There is no plateau. There are 2 convex surfaces. And in real life, they're not the same radius. So we measured the curvature here of the condyle of the femur, medial condyle, and of the condyle of the tibia, medial side, and it turns out it's about 1.5. The tibia has a larger radius of curvature by about 50%. And if that is the case, this angle by which you need to rotate is not twice as large, it is 1.6 times large. But that's still a big, big difference, 1.6. Or the other way, alpha is 0.6% of beta, 60% of that angle. So TPLO rotation is only about 60% effective. When you turn 20 degrees, which is what you do surgically, the effect is not 20, it's only about 12 degrees on average. And that explains that first difference. Now, where you get this effectiveness depends on not only on the ratio of the radii of the 2 sides, but where you pick your center of rotation. The further down you go, the more you have to rotate to get the same effect. That's all simple geometry. So now we come to leveling. And this is Tobias again. This is Barclay-Slocum's picture. This is the assumption of how things work here. And there is this axis of the tibia. And supposedly the force between the tibia and femur runs in this direction. This defines TPLO. Without this, we would be doing something else. So this is the reference, the long tibia axis here. And this implies that the joint forces are the only 2 forces that act on the tibia. There are no muscles touching the tibia. If that was the case, it would be okay. And that's what I understand Bartley used to show, here's my tibia, and I push like this. Well, that's correct if there is no muscle touching, but there are plenty of muscles attached to the tibia, and they're all here on the proximal side, and they all pull which way? Caudally. So if everything that touches here, all these muscles we just discussed, even the quads are pulling caudally. If they all pull caudally, you've got to push back opposite to this, or it's not going to be stable. So this is such simple picture that you have to reject this picture. This is not right. Now, the same page in the book, there is this picture, which is the beginning of TTA. This is justification for TTA. And what we said there is the force here is parallel to patellar tendon. This was done on a simplified picture of forces, assuming that there are no hamstrings. But we know there are no hamstrings, and this, if they're there, it's going to help us, because that's all going to pull this way. So this is also a simplification, but it's much closer to real picture. At least it could be about right. So now what do we do? If we're going to do something rational about TPLO planning, we have to change this whole process. We're going to say that the force is parallel to the patellar tendon. The same thing we say for TTA. We'll use that as a basis for TPLO planning as well. The medial condyles on the femur and the tibia are convex. There's no discussion about this. They are convex. And if you're going to do the planning, you need extension. You cannot do the planning with the leg at 90 degrees flexed. You just cannot do it right. So we need good x-ray to start with. And this is roughly what we do here. If you look at this now, we quickly look at the axis of the femur, and the tibia angle is 143 degrees here, so that looks like extension. Should be full extension. And now we do this. We are going to outline the shape of the condyles of the femur. They're not identical in shape. It's a perfect circle in the medial lateral view. And the other one, which we're looking at now, is the medial condyle, which tends to be more flat here, which is the area which comes in contact with the tibia when the leg is extended. So this circle is quite a bit larger. This is the center. So that's the medial, and because we cannot see the lateral condyle on x-ray, we're going to use medial. It's just something that's convenient. So now we do the same thing on the tibia. That's the circle on the tibia here. Find the center, connect these, and then 90 degrees to this is what we call common tangent. That's a very simple concept. It's just something that divides two convex surfaces. So now here's the patellar tendon. There is no patellar tendon action in TPLO picture. It's just not there. There are no quads, there's no pull on the tibia, none of this on the patella. So we do have a force, because without this force, this is going to flex. You cannot do anything without having at least this much. We've got to pull on this. So if you're going to do TTA, we draw now the line here, parallel to this line here. And we know if you're going to do TTA right, we need to rotate this by about 14 degrees in this case. So what do we do now for TPLO? We draw a line parallel to the original position of the patellar tendon through this center here. So it's just a line parallel to that. And we have basically everything we need now to do the planing. We have to pick the center rotation, which is here, intercondylar eminence. This is the angle we need to rotate by. From here, I think you see this from here to here. You measure that angle, 26 degrees in this case. So you got to do TTA 14 degrees, TPLO 26 degrees, and you'll get the same result. It is a forward-looking, whatever procedure, step by step, and you can do good planning. This is just another x-ray, and where you see the angles, here's the patellar tendon line. Here's one circle, two circles. We draw this line parallel to the patellar tendon here. We pick the center rotation, and this is our angle. And if you read the numbers, which I can't here, I think it's 22 degrees, isn't it? This is the angle that you need to rotate if you're going to do TPLO. It takes about 5 minutes or maybe 2 minutes if you get good at it. So we took 20 different cadaver legs. The table has a lot of numbers. In the summary down here, we compare now what you would do with standard planning against what you would do with this common tangent method, as we call it. And so what happens here? If you target -5 degrees, so you don't go to 0, you go to -5. You overcorrect by about 3 degrees. So there is an overcorrection. On 20 randomly selected legs, you're about 3 degrees over the average. That's not a lot, especially if you look at the effective effect of this, right? Effective effect, yes, it's only 1.8 degrees, so that's not a big deal, 2 degrees error. But there is a maximum overcorrection in this small sample of 8.4 degrees. This now starts looking like serious overcorrection. The average is only 3, but we have one now, which is 8.4 degrees. And then we have another one, which is -5.5. Now, if you went for 0, you can add to this 5 degrees. So that would be an overcorrection of 13 degrees, 14 degrees. That's quite a bit, isn't it? And we wouldn't have any undercorrection in this sample. So to summarize this, 12 out of 20 were overcorrected by more than 2 degrees. 2 out of 20 were undercorrected, and then 6 were within 2 degrees. So 60% overcorrected, 10% undercorrected, and 30% within the range. So here's a study that Scott Banks showed from University of Florida at BOS 2018 last winter. 16 dogs down in Florida with TPLO, 10 out of 16 in gait, as they use this fluoroscopy. The femur is subluxating cranially. It's moving cranial, they're overcorrected. So 2/3 of dogs are overcorrected. 5 out of 16 are subluxating caudally, they're undercorrected. And only 1 out of 16 is about right. I suppose in Florida they should know how to do TPLO planning and how to cut and turn. So if you compare this just to our sample of 20, well, it looks about the same, 60% overcorrected. I'm not sure if they go for 5 degrees here, I suppose they do. So now it comes to this big question. There is validation and there's verification. These two terms get kind of mixed in discussions. So what is validation? Well, this is the definition. You want to make sure that what you claim your product does actually is correct. It meets whatever your criteria is. And then verification says you get what you aim for, right? So they're not the same terms. That's the definition from this guide for the product. What is this? Project management. You can find this on Google easy. Now, what does that mean in our context? If someone comes to you and says you do TPLO, you do TTA, whose job is to validate that? Whoever's proposing it. So the job of Barclay Slocum was to tell you TPLO, I validate it, it works for you. Or for TTA, was we had one-to-one clinical experience we talk about, who said, I did it, it works. This is validation, right? And then verification is on your side. If you do TPLO or TTA, you should verify that what you're told or suggested to do, that you actually did this. If you don't do this, it's not right. So these two are very linked ideas. So then the question comes, did we actually validate our procedures before suggesting to you to go ahead and do it? Well, by Slocum, certainly, he didn't do any in vitro that I know of. It was his clinical experience. He's done hundreds of dogs, and he says it works. So that's validation by clinical experience. And then comes this paper, which is quoted many, many times. I guess this was maybe the first in vitro study that was supposed to validate TPLO planning. So how does this look? I tried to find out from Loic, because he was the mentor to YZ, what actually this jig looked like, and he couldn't really tell me. I don't know, Mike Oleski, where you knew about this, but you told me what this was like. So if I'm correct interpreting, because these pictures are just what they are in papers, the femur is fixed to the upper frame here, to this beam. Leg press, this is called. So we fix the femur. It cannot turn here. This is not a joint, it's fixed. It's potted and then fixed. And then we load it. And to support that load, you got to put something here to simulate your Achilles tendon here. So we put a turnbuckle and some cable or so to hold this together, and then we load this. So what is now the freedom of movement of that tibia? The femur can move only up and down. There's nothing else femur can do. So you cannot change the flexion here by this jig. you can push the tibia out, and the way it moves here is this way, but the center of rotation is down here. It's not just translating, it's rotating around the hock here. So there's 1 degree of freedom here in this jig, this experiment, and it's not what you would consider natural because the flexion, extension is not allowed to change in this jig. So now what happens here, this is a bit tedious diagram here, but I'll go through this. This little spring that pulls on the patella is just arbitrarily chosen little spring to just keep the patella in place. There is no force coming through here of any significance because femur cannot move. You just push straight down. Now if you push them straight down with something which is convex on a convex surface here, the only way those two cylinders can push against each other is 90 degrees to the common tangent. So what is the force here, this setup? It's going this way down, these black little arrows here. That is coming cranially, isn't it? With respect to the axis of the tibial. So what do you do now? Well, you got to do your TPLO and turn this. How far do you need to turn this? Until the common tangent, which now moves together with your plateau by just half of the amount that you turn the plateau, until this force now, the new position, goes where to? It goes to the hook joint. So by doing this experiment in vitro, whoever did this and set it up, actually it was validating Barclay-Slocum's idea about which force goes where. That's not what really happens. So this is validation of the wrong concept, right? So if you fix the femur like that, you can't have flexion extension. You have that 1 degree of freedom, and your result is not going to be anywhere close to what it is in real life. Without quads, there's no function of the joint. You've got to pull on the quads, and the quads are irrelevant in this setup. So, tibia is rotating there. Yes, it's unstable, and we're going to do how much rotation to make it stable. And by doing this, we're going to aim it at the hock joint. So, Varzi, again, validates the wrong concept. It does not validate anything that looks like in vivo. And this tibia axis should not be used for this. So now we're trying to validate our concept of planning by common tangent. We started on this, we set up similar leg press everyone uses, but we allow flexion. If you don't allow flexion, it's not going to be anywhere right. So we did 15 legs, intact, transected, cruciate, and TPLO corrected. And each one of the tibias we fixed into position, the TPLO, either according to standard method or common tangent method. We did the x-rays. This is all very much like RZ, already 30% of the body weight. And here's what happens. Intact leg on the left side here. This is the plateau, which we like to draw the line so we have some reference. We go through the intracondylar eminence here, we do 90 degrees. This is the center of a circle which fits on the caudal part of the femur, the condyle. And this distance here is what is in the normal intact leg. You can measure this in millimeters. And then you transect it, and here's what happens. It drops down by 13 millimeters. That's all very kind of expected, nothing surprising here. Here's just another leg. We do the same. This is intact. We cut, and it drifts now caudally again. This is the other side. It goes by 13 millimeters. So now comes comparison between the conventional method and the common tangent method. And in this particular case, there was a 9 degrees difference. The common tangent calls for 9 degrees less rotation than the conventional method. So here it is, it's transected. This is where it is, it's stable. But this one is just the same position, even though this is rotated 9 degrees less. So then the question comes, why would you rotate 9 degrees more if you don't need to do this? This is an overcorrection of 9 degrees. Now, we're going to repeat all of this because the method you've just seen that Chris shows is much more convenient than doing x-rays. We're going to run this one more time, so hopefully we can verify now what we've seen using the fast direct device. Just another thing. So now comes this big question. How come TPLO works, ever? 1 million dogs are done probably in the last 25, 30 years, and all the dogs are happy, and the surgeons, everyone's happy. it does happen because there were two errors in this whole thing that approximately cancel each other. One is using plateau as a word to define something which is not plateau, and then the other one is mechanical exit. And those two are about 10 degrees in the opposite direction. So you make two mistakes and you end up okay, within a few degrees. The question is, if you overcorrect by 10, 15, 20, or 30 degrees in those extreme slopes, are you doing damage that you don't need to do, right? So the meniscal release, which we're going to hear a lot more about today still, I'm sure, is probably the consequence of overcorrection. It's hard to explain what else was there to cause Barkley to go and cut meniscus. This RZ study gave you a fudge factor of 6.5 degrees, which is now kind of rounded to 5 degrees, but it's not based on any real mechanics. There's no mechanics in there. It's just an experiment which was set up wrong, gave a wrong result, and gave you a correction of 6 degrees, which is based on the wrong experiment. You could probably just pick any number between 5 and 10 and get the same thing. Now, the point here is you can do it right. If you're willing to spend another few minutes on your planning and you get a good x-ray, you could do it. You need extended stifle. It's not easy to get that, but you need to learn how to do it. And then you need to pick your center of rotation. And whatever you pick on x-ray, you need to do this in surgery. It does matter where you put that center of rotation. And at least in old Barkley's pictures, that center of rotation is much more distal than it is today. And the more distal you go, the more rotation you need, which is probably why he went to 0 degrees, to compensate for the position of the center. So what do you need? Instead of 2 lines, you need 3 circles and 5 lines. It's not so much extra work. And there is no fudge factor now. You just go for every dog, you can plan exactly the way it deserves, and you execute that. And we just kind of need to forget the long axis, the slope, plateau. Those terms don't make any sense. And we can talk about common tangent as we do for TTA. And in a way, it's nice because it ties TTA and TPLO together. Mechanically, they're equivalent in a way. So what happens here? Well, you don't have to study all of this. You can just imagine these two bones are being squeezed together. I mean, that's what happens around this. And what's resisting this? Without the pull of the quads, you're not going to resist that. You got to pull real hard. The harder you have to pull, and it has to do with the distance here between here and here, you compress these convex surfaces. And that is nearly parallel to that. That is what sold TTA to Pierre and everyone else, that this is parallel to this. And I think we can keep that concept for basically TPLO. TTA, is TTA any better in that respect? Well, a little better. Because this picture here, which started TTA, makes a little more sense because we include something which is essential, which is the force of the quads going through the patellar tendon. Without this, you can't discuss the picture. So that's the beginning of TTA. And the message here is very simple. Joint reaction is approximately parallel to the patellar tendon. And that's your target. You want to do TTA so you get that parallel thing at the end. So I was surprised, but I was asked to talk about this in Barcelona. And I looked through whatever we've done over these years. We've done at least 20 in vitro studies. And each one of those is get a number of legs, get a number of people, surgeons, to do the procedures, put them in some sort of a machine and crush and test. We've done more than 20 of those over the last years to validate in vitro both TTA and TTA2. TTA2 was a much bigger project in a way than TTA. And we wanted to validate the concept. Did we do it right? Well, there's some little holes there. I'm not going to present our own errors in as much detail, but they're obviously there. Because you can design your in vitro test to demonstrate what you want to demonstrate. That's quite clear. But you should at least include the important factors, right? We did a lot of this to make TTA a better procedure. It wasn't just to show that it works, because as with Slocum, when Pierre did the first dog, and the first dog 2-3 weeks later is walking happily, that's what you kind of believe. This is validation for each one of the surgeons. Improved planning is the big deal. When we talk to people that are doing TTA now for 15 years, and they have not stayed in touch, even though we try pretty hard, send out all these nice things that can prepare us here, those things on a ring. Here is how you should plan for TTA. Most people are not responding to that very well. So our planning is sometimes still very primitive, as it is for TPLO. So we're all very lucky with this. The implants we did improve. We made them in smaller increments in size and so on. And here's 2 out of 20 studies were published. That's a rather miserable record, but that's what it is. There are a few others that are published on in vitro TTA. But here's the real picture. This is not what we know how to analyze. Bob Mans, he is professor, advisor to both Gate and myself here at MIT. He was working on gait analysis for decades, and these two people, Neville Hogan, you might have heard 4 years ago, he was presenting, and the guy from physiology, they did this beautiful study on co-contraction and redundancy. And it makes it all so complicated, no one's going to do this, not in surgical circles. So we just have to be kind of mindful, this thing is much more complicated, and everything we do, we had a great luck with, so that it works about right. TTA, we started with 1 cage size, 10. That went on for quite some time. Then we had 6, 9, and 12. Then we started planning with common tangent. Then we had these nice corrections for how you do this and plan and all of that. Was it all worth it? Well, I think it was, because at the end you look at what the clinical picture of this is. Now, in vitro validation, there's a lot more that was done here too. I'm sure some of these have significant detail problems, how the experiments were set. They're all kind of saying you go to 9 degrees. Now, this is probably the most important. I think this is most important. You will hear Andy talk later today and tomorrow. Over 2,000 cases followed up and look at them. And look at the meniscus as the problem. Because if you don't cut meniscus, you have a sensor in the joint that tells you did a good job or did a bad job. If you cut meniscus, you have no idea what you did. The dog is walking, that's all you know. But if you don't cut it and it fails 6 weeks or 6 months later, something's not quite right. So the survival of meniscus is the best evidence that you've done a good job. And I think we shouldn't cut it, so we have that feedback from meniscus. Ray Prata, first 200 cases were published and then 300 unpublished. What's the summary of this? The damage to meniscus, if you do it about right, has gone from 30% initially, 15 years ago, to 3%. I should say this was not in everyone's hand, because this would never survive going out of surgery if he had 30% meniscal damage. But Pierre was doing in all of these cases upper neurotic sling, which I believe now we should re-evaluate and say, let's not do upper neurotic sling, let's just pull a little extra, because chronic cases need this little extra pull. TPLO you can overcorrect as much as you like. TTA you cannot. There's a very definite limit how much you can overcorrect TTA. So in chronic cases we needed that little extra pull. But we did anyway go from 30% to 3%, and that's in those that are at risk, which is 50% of all those that come in. So if you look at the overall population, you can have 1.5% of meniscal problem if you do TTA correctly, if you verify that you do it right. So this is what we do. We plan. Plenty of this was done. And here's now something that really puzzles me. Everything that Antonio Pozzi and Stan Kim have done over these, whatever, years, many years, and published many times in beautiful studies and papers, in every one of those papers looking at contact pressures between TTA and TPLO, TTA was always better. I don't think there was a conference where they didn't win the best presentation. The ECVS, VOS, and so on. So I sit here, and I stand here now wondering, where is this war on TTA coming from? Because it is kind of a war. If you do TTA, you're under attack today. And I hope you're going to have a little bit of guts to not just give in. There are defenses out there. Maybe we can provide a little bit of this. But I leave this to our debate, which is coming up, which is probably the most exciting part of the day, between Michael Oleski and Andy Torrington, to try to clear this thing. Where are we today? All right, thank you very much. Actually, we're on time, aren't we?